I would like to invite Dr. Freilich for the next topic, VTE secondary prophylaxis, when to choose DOAC versus aspirin.
So thank you again for allowing me to participate. I was told we're going to get the hook if I stray over. Brett set this up very nicely in the discussion of provoked versus unprovoked, and I think what this title for my talk is meant to ask is, if you've decided the patient needs extended therapy for whatever reason based on the data you looked at in the last talk, then what would be the preferred agent, a DOAC or aspirin? These are my disclosures. I've consulted for everybody who makes an anticoagulant. I'm putting two boys through medical school. So the data, to summarize very quickly, this slide shows what the results of dabigatran versus placebo randomized trial for extended therapy. Two take-homes, dabigatran works, and if you stop giving it, it stops working, surprisingly enough, and compared with warfarin, it works just as well. And this is for bleeding. There's actually less bleeding with dabigatran than warfarin in extended therapy after VTE. Aspirin works too, as you can see, not so much, but it does work. And interestingly, if you add the adverse events, it actually works even better because there's so little bleeding with aspirin, and there's additional benefits besides preventing recurrent VTE, such as preventing heart attack and stroke. Rivaroxaban, this is the Einstein choice that Brett mentioned. Rivaroxaban compared with aspirin in extended therapy for VTE prophylaxis. Rivaroxaban works too, is the take-home here, and it works in 2 different doses. And when you compare it with aspirin in terms of bleeding, it's virtually indistinguishable. Finally, apixaban works too. This is apixaban versus placebo for extended prophylaxis. In both full-strength and half-strength dose, it seems to work just as well, incredibly effective versus placebo, and even more enticingly, virtually indistinguishable at the low dose from placebo in terms of bleeding complications. Slightly more bleeding with a full dose of apixaban. So what do the guidelines say? I think guidelines these days, especially in a field like this, are pretty much out of date as soon as they're printed, but the guidelines say for an unprovoked VTE, a patient should get extended therapy unless they're at really high bleeding risk. And in terms of agent, they just say simply there's no need to change just because you're going to continue therapy indefinitely. And as far as aspirin is concerned, they say if you are not going to anticoagulate, then it's better to give aspirin than nothing, because as you could see in the previous studies, it works, but certainly not nearly as well as DOAC. So how do we sum all this up? And I think this basically involves a close conversation with your patient and what their other comorbidities and risk factors are, what their preferences are. I think anticoagulation scares people disproportionately, especially when you're talking about lifetime anticoagulation. But what we know from the studies is DOACs work. They clearly cause less bleeding than warfarin, so that's a better option. Aspirin is less effective, but it is another alternative. And honestly, both of the low-dose DOAC studies really are a game changer, I think, in this discussion. Because now all of a sudden, we have a whole bunch of options. Pretty soon after our confirmation of the discovery that idiopathic and unprovoked VTE confers lifelong risk, now we've been given multiple options, some of which have really low risk for bleeding complications to mitigate the ongoing risk of VTE. So I think, obviously, for most of my patients, I'm recommending low-dose DOAC, but that has to be done in light of their other comorbidities and the pros and cons of aspirin and their willingness to take it, and cost. So I have 40 seconds left. I don't have any jokes. Thank you.